All right, so let us get into the beta lactams. So we are at this stage now, and just, of course, a quick reminder, it's edutainment. Always make sure you're consulting your antibiogram. Don't always make sure you're both practicing judicious use of antibiotics, but also not underutilizing them, particularly for sicker patients. And remember, it is on you to always confirm side effects, and certainly a number of other ones can come up that we don't necessarily talk about all of them. All right, so with that being said, let us get into the beta lactams. So let's zoom in on this copy I made. All right, that should be good. So we're here. We finally made it through translation and blocking the ribosomes, and now we're on to stuff. And the vast majority of antibiotics from here on out are really the antibiotics that work on the cell wall. There's a whole bunch of enzymes that are important in dealing with generating the cell wall. We call them, because they bind penicillin, we call them the penicillin binding proteins. And there's a whole bunch of them that are involved in the peptidoglycan cell wall synthesis. But probably the most important step of that in terms of antibiotic function is the cross-linking step. Now, you probably remember being told, okay, well, it pokes holes in the membrane, and that's probably a little bit of a simplistic view of it, because it turns out that it's the cross-linking is especially important when we're talking about cell division and mitosis. And when the little buds start forming off of the bacteria, and they start to pinch off and close, that's when those cross-linking enzymes are especially important. So when you actually look at cells under the microscope that have been exposed to beta-lactams, you'll see a lot of sort of dysmorphic cells that have essentially broken apart, and it's probably during that division phase when they're so important. All right, so let us get into the granddaddy or grandmama of antibiotics, and that is good old penicillin. Penicillin. So what does penicillin work on? Now, if you're back in Alexander Fleming's time, he would tell you that penicillin was an excellent antibiotic against MSSA, and there was no such thing as MRSA back then. But he was also the first person to point out that Staph aureus, when you give penicillin, seems to develop resistance. And when you read his documents about penicillin, he even mentions how difficult Staph aureus is. And what happens with Staph aureus is it produces a penicillinase, right? So one of the easy ways to deal with penicillin is to just chop it up. Remember, these are beta lactams, so they have that lactam ring, usually attached to another ring, either 5-carbon or 6-carbon, depending on whether it's penicillin or it's a cephalosporin or it's a carbapenem. They're going to have different rings attached to the beta lactam ring and R groups that stick off of these special rings. So here are R groups, and those are what's really ends up distinguishing the beta lactams from each other. So, the easy way to deal with this is you just hydrolyze this ring here, and you hydrolyze that ring, and that's the end of it acting like one of the cell wall components that binds to the enzymes and renders them unusable. So, we learned that unfortunately MSSA, or Staph aureus in general, all Staph aureus really, or the vast majority of which, will now produce a beta-lactamase. Lactamase, which will cut up that ring, so rendering it essentially useless for Staph aureus. There are a few, like maybe about 1 to 5% of Staph aureus that have not gotten the memo yet and still do not produce a beta lactamase, but those are quite rare. And I think most of us would worry that that's just a lab error before we believe that it was a Staph aureus that was somehow resistant or somehow still susceptible to good old penicillin. But that's the story of that. Now, on the other hand, Group A strep has never gotten any memo, and at least for now, Group B strep also has not gotten any memos about beta-lactamases. So the vast majority, in fact, as far as we know, 100% of Group A strep is still susceptible to penicillin. So it is an excellent antibiotic for Group A strep. And it remains an excellent antibiotic for Group B strep, although there's been a little MIC creep over the years, so we do have to worry about that. Similarly, Group G, Group C strep both remain highly susceptible to penicillin. So it's an excellent antibiotic for that. So yes to Group A strep. Viridin's a little bit smarter than Group A strep. So there is some higher level resistance to penicillin, and pneumococcus, and we'll even talk about that when we get into AMP and amoxicillin, is even better about resistance to penicillin. So about 60% of pneumococcus remains susceptible to normal dose penicillin. And this is a question I'm sure you're going to get asked a million times when you're on wards and tests and all this other stuff. But what is going on with these other 40%? Why are 40% not susceptible to normal dose penicillin? And the answer is that it, unlike Staph aureus, which produces a beta-lactamase and just cuts it up, it develops alterations in the target. So altered penicillin binding proteins. So again, don't forget that. You're going to get, like I said, you're going to get asked a million times, so I'm giving you a free answer. About these other 40% are going to alter their target. So the penicillin binding proteins, the enzymes here that are important in making the cell walls, will change their structure a little bit so they don't bind penicillin quite as tightly, and that is why they become resistant. Now, the good news is, for a lot of the strains, if you just up the dosage of penicillin, you will be able to now overcome that binding protein resistance and force the binding just by increasing the concentration. And that works about 30% of the time. So about 30% of the time, you just up the dose, you will get this, you will get these additional 40%. Or I guess the better way to say it is, if you increase the dose, not only will you get the 60% that remained highly susceptible, but you'll get an additional 30% that have altered the penicillin binding proteins, leaving only about 10% that are non-susceptible to penicillin. Cool. Okay, so can a pneumococcus alter its penicillin binding protein sufficiently such that it does not bind to penicillin at any reasonable clinical concentration? The answer is yes. So that's what happens with these 10%. They have just altered their binding proteins enough that they simply do not bind penicillin in a way that you can just keep upping the dose without causing all the toxicities. Remember, even though the beta-lactams tend to be our safest antibiotics, we'll talk about a few, toxicities associated with them, but in general, they're very safe. But at some point, there remains a therapeutic window. If you just go too high, you will start running into toxicities with them. So that's what's happening here. All right. So again, Staph aureus produces a beta-lactamase. Strep pneumo alters its penicillin binding proteins. Comparatively, remember, Enterococci, superstrep pneumos, fecalis remains typically exquisitely susceptible to penicillin in most cases. Actually, ampicillin, interestingly, is the drug of choice for them, and we'll talk about that when we get to ampicillin. But Faecium, you have to be a lot more careful. It tends to alter its targets a lot more and has much more penicillin resistance, and of course vancomycin resistance in general than compared to fecalis, though either can have it. So then that gets us into the gram negatives. Does penicillin work on the gram negatives? And the answer is no. Penicillin, unfortunately, does not work on your gram negatives, with one exception, and that's good old Neisseria meningitidis. Neisseria meningitidis, for whatever reason, has remained very susceptible to penicillin. Gonococcus used to be susceptible to penicillin, but that era is long, long gone. Just Neisseria meningitidis is the only one of these entire group that is. And that's actually when we talk quickly about ampicillin, what ampicillin addressed, at least back in the day anyway. So the next question is, does penicillin work on atypicals, right? And then should it not? Let's think about that. Can you reason your way through whether or not penicillin should work? Then I'll give you the answer. The answer is absolutely not. Why? What makes atypicals atypical? What makes atypicals atypical is that they do not have a peptidoglycan cell wall, or they behave in a way where even if they have a peptidoglycan cell wall, they don't blocking the cross-linking enzymes does not seem to affect their reproduction. Similarly, like for instance, chlamydia or Legionella. So, and mycoplasma simply doesn't even have it, so how would you inhibit something that doesn't? And that's going to be true for basically all of the beta-lactams. So the answer will always be no atypical coverage, because even their carbapenems, like meropenem, so broad, right, a huge gun, will not bother working, or the bacteria that, the atypical bacteria don't have a cell wall, so it doesn't matter how big a gun it is if you simply lack the underlying mechanism. And that's why it's still important to kind of have some idea of how these mechanisms work. In terms of anaerobic activity, it does actually have gram-positive anaerobic activity, like for instance, tetanus and wound botulism, if you have. You will be treated with penicillin because it works quite well on those. Unfortunately, C. diff tends to be more resistant. Perfringens is hit and miss, but no gram-negative anaerobic activity. Similarly, mycoplasma from their mycolic acid cell wall, even though mycolic acid shell, excuse me, even though they in theory could do have a cell wall underlying this, will not have any activity. So you're pretty much done there. All right, so that's penicillin. What can you use it for? You can basically use it to treat group A strep and syphilis. At high dose, you can also treat certain pneumococcal infections, and fecalis infections. But by far and large, you're going to use it for syphilis, group A strep, and syphilis. And that is penicillin. So let's talk about ampicillin and amoxicillin, all right? So let's move down a little bit, and we'll talk about, let's erase here. And let's see what it brings to the table. Let's just kind of erase this stuff. So we had penicillin, and then we have the aminopenicillins. And that is AMP, and its oral form, amox. There is actually oral ampicillin too, but it's not well absorbed. But that'll be a free question later. All right, so we have our aminopenicillins. What do they bring to the table? Do they have better MSSA activity than penicillin? Think about that one question for a second and then decide, what do you think the answer is? The answer is no, right? If you have a beta-lactamase, ampicillin and amoxicillin are not in some special way resistant to beta-lactamase. And so will they get cut up? They absolutely will. So do you get any better MSSA activity? Absolutely not. Do you get MRSA activity? No, they both have a beta-lactamase. You're going to cut up the ampicillin and amoxicillin just like you did the penicillin, and no activity will be there. So do you get better group A strep activity? The answer is absolutely not. In fact, penicillin remains an excellent and nicely narrower choice for treating group A strep. So use penicillin. But ampicillin and amoxicillin absolutely will have perfectly good group A strep, group B strep, C, and G strep activity. Let's talk about pneumococcus again. Because especially in pediatrics, you're going to be using a lot of amoxicillin. But why? Why not penicillin? There's two reasons. One, amoxicillin, which I'm sure you've already guessed, amoxicillin tastes delicious, penicillin does not. So that's already one benefit for amoxicillin. The other is curious. So let's take two patients, right? The first patient has they both have acute otitis media, right? And we've already decided it's not a viral infection. They really have one ear that's bulging. It is painful. You look at behind there, and it's erythematous, and there's a purulent discharge, and it's sticking out. And the kid has a fever after a cold, after a couple days of cold. So that looks like a true acute otitis media. What are the bugs? There's a couple bugs that we need to think about. Of course, pneumococcus being one of them, and where are we here? Haemophilus being the close second, if not tied, and then of course Moraxella is a different distant third. But let's just say I know, just I divine, I have a tricorder and I scan them and I know that it's pneumococcus sitting in their middle ear. I give them both IV penicillin and ampicillin at high dose. Remember, we do have to worry about the altered penicillin binding proteins. I give them both, and for some reason, the kid, both of them get better, right? Great. So then they're starting to get better, and I decide, all right, well, I'm going to now put them on an oral antibiotic. So I can put one of the patients on oral penicillin and the other on oral amoxicillin. And I will tell you that the kid who was on oral penicillin, even though they have the exact same strain, did not get better, whereas the oral amoxicillin kid did get better. Why is that? Why would one, even though they were both getting better on IV, not get better with oral? And hopefully you've guessed by now, but the answer is bioavailability. Now, actually, most of the antibiotics we've talked about so far have excellent bioavailability. So, but unfortunately, penicillin is not one of them. Penicillin just doesn't have the same oral bioavailability that amoxicillin does, whereas maybe only 60% here is absorbed. 90 to 100% will be absorbed here, which means you can essentially, if given the same oral dose of amoxicillin as ampicillin IV, you'll get roughly the same concentration in the bloodstream, whereas penicillin you will not. And if you remember, what's the mechanism of resistance of pneumococcus? Hopefully you're already screaming out the answer. It's altered penicillin binding proteins. If you need to overcome the resistance, then you need to get high dose. And the only way to achieve high dose is to give high dose oral amoxicillin. And that will achieve similar blood levels to giving high dose IV penicillin or high dose IV ampicillin. Whereas oral penicillin, you just simply won't get that same blood level that you would. And that's why we tend to always use amoxicillin. Both the taste, so it's a 2-for-1. You get the taste and you get the bioavailability. So you're good. Ampicillin, like we had talked about, has poor oral bioavailability, and so therefore it's not necessarily that great for that, and that's why we just stick with amoxicillin. Fecalis, though it is generally penicillin susceptible, the order of dilution is a little bit better for the aminopenicillins compared to penicillin for E. fecalis. So it is what we consider to be the drug of choice for Enterococcus fecalis, the aminopenicillins. But in general, if something's susceptible to ampicillin, it'll remain susceptible to penicillin. It's just easier to kill it, and you get a little bit better killing. Gram negative. So we had crossed this whole section out with penicillin, but this is actually where things differ with the aminopenicillins. In fact, the whole raison d'etre of the aminopenicillins was that, at least back in the day, they did treat E. coli, they did treat Klebsiella, they did treat they did treat E. coli. Unfortunately, Klebsiella has intrinsic resistance, so no Klebsiella, but they would treat a number of these bacteria. In fact, there's still Salmonella strains that are penicillin susceptible, or ampicillin susceptible, that we find. In fact, there's still E. coli that are susceptible. So I've treated plenty of urinary tract infections with good old amoxicillin or ampicillin, just because it happens to be susceptible. The problem is, as you can remember with gram negatives, is they're just really good about harboring drug resistance. And a majority, if not a large minority, the majority will have beta-lactamase production, and usually stored on a plasmid. So those are those little circular bits of DNA that hang out. And remember, it's in the era of multi-drug resistance. When you get one thing, you get a bunch. And so these tend to be quite resistant. And so you really have to know that the E. coli that you're treating is susceptible, which still happens. It still happens quite a bit. Ampicillin and amoxicillin, the aminopenicillins, do not have any pseudomonal activity, and really no steno, no Acinetobacter. Again, Neisseria meningitidis, the aminopenicillins are going to work for, but gonococcus, unfortunately, that era is long gone. Now, Haemophilus is an interesting story. About half produce a beta-lactamase, but that means about half do not. Hib is a little bit more likely to produce the beta-lactamase, but it's about 50-50, which means that if you've got a kid with an otitis media and the otitis media is already, not due to a virus and but is due to a bacterial infection, and you do need to treat it because let's say a couple days have gone by and it hasn't self-resolved. Now all of a sudden, you're dealing with probably most of your, so with high dose oral amoxicillin, you're getting about 90% of your pneumococci, and you're getting about half of your Haemophilus. Now remember, unfortunately, with enzymes, just increasing the dose won't affect the susceptibility profile. Remember, enzymes are really, really good about just cutting up everything. Remember, you're in that, if you recall from your biochemistry, enzyme kinetics, right? They have that sort of um, logarithmic scale, right, where it starts off with low substrate, you have low activity, but as you increase it, you essentially are in this exponential phase where you're just cutting up more and more until you saturate it. The problem is there's almost no way reasonably physiologically that you're going to be able to saturate the beta-lactamase enzyme with beta-lactam substrate and overcome that, because you're just going to be stuck in that phase. Unless you turn the patient's blood into a beta-lactam, you are not going to have much success with those. All right. So high dose will work for pneumococcus, will not work for the half of Haemophilus do. Moraxella will always, or at least 90 to 95% of cases, produce a beta-lactamase, so you're pretty much dead in the water with that one. And it certainly doesn't work on pertussis. Again, does the aminopenicillin addition affect atypicals? Answer, no. Stop asking me that question. Why? Because atypicals don't have a cell wall, so it doesn't matter. In terms of anaerobes, B-Frag almost always produces a beta-lactamase. So you are not going to get any benefit of your gram negatives with ampicillin unless you add something. And so we'll get into that in just a second. All right, mycobacteria, same deal, no improved coverage. So where can we use ampicillin, or sorry, amoxicillin or ampicillin? We can still use it. We can't use it for staph infections. We certainly can use it for group A strep infections. And since it tastes better, I think a lot of people will end up using oral amoxicillin rather than penicillin, unfortunately, even though penicillin is the right answer. We certainly, I have also been guilty of just using amoxicillin because it was just easier for a kid to take. But if you've got an adult and they want to just a shot of penicillin, that's probably the best way to actually treat them. But most parents don't want their kid to get a shot. Most kids will tell you they do not want to get a shot, and so they'd rather have delicious bubblegum flavor amoxicillin. Fecalis is certainly something, and you can use it for UTI. Like I said, you can use it for UTI. You can even use it for certain non-typhoidal salmonella strains if they're susceptible. We've certainly had a few cases where we could treat it with good old amoxicillin, but not really helpful for most of the other ones, with the exception of course, Haemophilus. All right, so we've talked about the aminopenicillins. Let's just keep chugging along here. And let us talk about piperacillin, what it adds to the table. So piperacillin is an interesting one. We'll talk quickly about it. It's fairly, I mean, it's just another penicillin with one exception. It, unlike other penicillins, also binds Pseudomonas's penicillin binding protein. So let's just talk about that in a second. All right, does piperacillin by itself give you any better MSSA coverage? It does not. It gives you the same group A strep, same sort of deal with pneumococci, perhaps a little bit less than ampicillin. Ampicillin remains the drug of choice for fecalis, but certainly has similar activity to fecalis as regular old penicillin. But here's where things start to get interesting. So we talked about uh, most of these bacteria producing gram negatives producing beta-lactamases. So piperacillin we never use by itself. We always use it in combination with a beta-lactamase inhibitor called tazobactam. And now all of a sudden, tazobactam is a suicide substrate. So, right, it takes itself and it jams itself into the beta lactamase enzyme and it kills it. So, what happens is now let's actually think back about what our spectrum of activity would be. Well, how is MSSA resistant to penicillin? Well, remember, Staph aureus makes a beta lactamase. But now you've inhibited the beta lactamase. So, do you get activity on MSSA? The answer is suddenly you do. You do get it. Fantastic. How about MRSA though? Methicillin resistant Staph aureus. So that gets into methicillin resistance, and we'll talk about the semisynthetic penicillins in just a minute. But let's talk about the beta lactamase inhibitors first. So does MRSA produce a beta lactamase? The answer is yes, it does, and you've inhibited that. Fantastic, you've inhibited the beta lactamase. So in theory, right, shouldn't it work? Well, what is the methicillin resistance? What is that MR? What is that MR part? And that comes down to the second mechanism. Think of it analogously to pneumococcus. If you alter your penicillin binding protein, then all of a sudden it doesn't matter that you've stopped the beta lactamase from cutting it up. If you've altered your penicillin binding protein, such that it no longer binds penicillin, then or methicillin or cephalosporins or any of those things, then you don't get any activity again, right? Because it's resistant. The penicillin binding protein is resistant to penicillin, and that is the mechanism. That is where the MR of MRSA comes from. It comes from a gene called the MEK-A gene, which creates a penicillin binding protein 2A. And this intrinsically does not bind the vast majority of beta lactams. There's going to be one exception to that. So we'll talk about that. But that is the mechanism of resistance for MRSA. It is now not only is it producing a beta lactamase, which is going to stop it, but it also simply won't bind the penicillin. So you're kind of dead in the water with MRSA with most of the beta lactams, with one exception. Group A strep, do you get any better Group A strep coverage from any of these combinations? The answer is no, right? Group A strep does not produce a beta lactamase. So inhibiting the beta lactamase, when you don't have a beta lactamase, doesn't help you in any stretch of in any way, shape, or form. So there's essentially no point to using it. Yes, you'll continue to treat it just fine, but why broaden your scope? Let's see, what else? Pneumococcus. Do you get better pneumococcal coverage with something like piperacillin, tazobactam, or the other beta lactamase inhibitors? What's the answer? The answer is no, right? Because remember, what is the mechanism of resistance for pneumococcus? It's not production of a beta lactamase, it's altered penicillin binding proteins. So you do not get any better coverage. You still get coverage just like you would with just good old piperacillin or ampicillin or penicillin, that you would. Otherwise, you're not getting any benefit or any additional coverage. I can't get better than 100% susceptible, right? Similarly, with pneumococcus, since it's altering its penicillin binding proteins, doesn't matter that you've inhibited the beta lactamase. Fecalis faecium, same deal. The one exception is rarely enterococci can produce a beta lactamase, but by far and large they also will alter their penicillin binding proteins. So you can, in rare cases, get better coverage, but it's really not something that is tested for very often in the lab, so you're not going to know. However, let's look at our E. coli and all these guys. Do these produce a beta lactamase? The answer is yes, they do. In fact, in most cases that are resistance, it's beta lactamase. So if you inhibit the beta lactamase, do you get better coverage? The answer is yes. And we'll talk about the list in just a second. This is where piperacillin shines, though. So Pseudomonas also, I mean, it's such a durable organism. It's the one with so many different resistances. It almost always produces a beta lactamase. So if you didn't have a beta lactamase inhibitor, you're dead in the water. Which is why piperacillin always comes with tazobactam, is because you need to inhibit that beta lactamase. But all of a sudden, you suddenly get pseudomonal activity because not only, like for instance, if you just paired AMP or penicillin with tazobactam, you would not get any pseudomonal coverage. However, piperacillin can bind pseudomonals, specific penicillin binding proteins, and so the combination of inhibiting the beta lactamase and using a penicillin that can bind it will give you anti-pseudomonal coverage. So all of a sudden, piptazo does have pseudomonal activity. So yeah, so let's come here. And ooh, can I get that without erasing the Pseudomonas? Now all of a sudden with piptazo, you do get pseudomonal activity. Similarly, with the broader ones, you will, in many cases, get Acinetobacter activity. What's really fascinating about Acinetobacter is actually the beta-lactamase inhibitor that tends to be the thing that kills Acinetobacter. So, in some cases, it's actually the sulbactam component that will do the best at killing Acinetobacter. Interestingly. But you do have to use kind of high dose to get enough of the inhibitor to matter clinically. Gonococcus, unfortunately, tends to be resistant regardless. Meningitis doesn't produce a beta lactamase, so you generally will remain susceptible. Haemophilus, all of a sudden, you'll go from half to essentially 100%. There are actually a few Haemophilus strains in the world, more particularly in Asia, that also alter their penicillin binding proteins, not dissimilarly from MRSA. And unfortunately, in those cases, you won't get better coverage. But here, at least in the U.S. and I believe in Europe, that's very extremely rare, and so you'll essentially get 100% Haemophilus coverage with the beta lactamase inhibitors pairs. Moraxella, same exact thing. Almost always produce the beta lactamase, so if you inhibit the beta lactamase, you get Moraxella coverage. And that is why, if you have an acute media with pneumococcus, and Haemophilus and Moraxella being the most likely three bacteria causing that, if the amoxicillin isn't working, what do we move to? We move to amoxiclav. So clavulanate is another beta-lactam inhibitor, beta-lactamase inhibitor that will block these two. And so if you happen to have an infection with Haemophilus, well, unfortunately, amoxicillin by itself is not going to work if it's one of these 50% that is resistant. Similarly, if it happens to be a Moraxella that's causing the acute otitis media, all of a sudden now you've got coverage again, whereas you didn't. Again, no improvement with atypicals, but anaerobes is where we start to see some difference again. And so let us just do a little eraser here. Let's talk about the pairings. So we have amsulbactam. We have amoxiclav. And we have piptazo. There was also for a while ticaricillin ticlav, which ticaricillin also happened to have pseudomonal activity, so that was, but I believe it's been discontinued, so it's sort of off the market. So let's just talk about these big three. So with all these three, do we have MSSA coverage? The answer is yes, we get MSSA coverage. Do we get MRSA coverage from any of them? The answer is no, we do not get any MRSA coverage because remember, altered penicillin binding proteins, not just beta-lactamase. So that's our staff. And again, we're not going to get any better group A strep activity than we already had. And again, we're not going to get any better pneumococcal coverage than we had from just the penicillin components. And again, same with that. But here's where this sort of ordering matters. When we get to our gram negatives, sulbactam is sort of our weakest. Clavulanate's better. Tazobactam's even better. So the gram negatives tend to supercharge their beta lactamases. That's their mechanism of overcoming resistance. When you have resistance, when you have exposure and you've got an E. coli and it's starting to become resistant, what is it doing? It's generally will be mutating its beta lactamase to produce ever stronger function or ever stronger enzyme activity against these inhibitors. Amsulbactam will only get a small portion of additional E. coli that are producing it, whereas amoxiclav will get more, and piptazo will get a whole lot more activity. But can E. coli become resistant to tazobactam? Absolutely, and we'll talk very briefly about some of the newer generation stuff. So, for instance, we have a whole mess of new beta-lactamase inhibitors coming out in pairings. I won't go through all of them, but at least at the time of the talk, these are probably the three most clinically used. But you will start to see, especially in patients who've been hospitalized for a long time, or there's outbreaks of multi-drug resistance. There's a whole bunch of other ones like meropenem, vaborbactam. There's ceftaz, avibactam. My goodness, there's just a whole ton more that are coming out, and ceftolozane, tazo is another one. So by adding all of these other bactams, they're trying at these multi-drug resistant bacteria that are now resistant to our usual three of maybe finding that answer. And the same with Pseudomonas, right? Pseudomonas, and that's why so many of these have pseudomonal activity, is because Pseudomonas is also extremely good at supercharging its beta-lactamase and becoming resistant. And the hope of these guys is that they are providing additional benefit, or they're able to block those, or able to inhibit those supercharged beta-lactamases, which can in some cases cut up carbapenems even, which is why it's such a problem going forward. Again, you don't need any of these for these guys. Amsulbactam is generally just fine for Haemophilus moraxella's beta-lactamase. It doesn't supercharge it the same way Pseudomonas and some of these more difficult gram-negatives like E. coli and Klebsiella are doing it, or for instance typhoidal salmonella, which is also developing multi-drug resistance. Again, no atypical coverage from any of these guys. Anaerobes, you do start to see improvement here. And in fact, sulbactam is pretty bad for B-frag, so that's why we call them good for the above the diaphragm anaerobes, so your Previtellas, Valinellas, those guys, which can sometimes produce a beta-lactamase. Amsulbactam is usually fine for those, but B-frag tends to be able to overcome sulbactam. It's about 50-50 for clav, so clav's a little bit better. And you can even see certainly in cases of appendicitis where, remember, you're just trying to kill enough of those bacteria. You don't necessarily remember you got your immune system. Most people, even in antiquity, would survive appendicitis even without treatment. But sometimes it's just better to reduce the bacteria count, and if you can give people that fighting chance, then their immune system also helps you out. And so you will see people using things like amoxiclav or second generation cephalosporins that kill some of the B frag, some of the other anaerobes, some of the other gram negatives, not necessarily every last one, because you don't necessarily need to kill every last one. You just need to bring the overall bacterial burden down enough to give the immune system a chance to fight it. And that's why you'll sometimes see amoxiclav being used in that situation. Even though it's not necessarily, if you had somebody with a ruptured appy who was dying of sepsis, amoxiclav would be a terrible choice. Whereas piptazo is generally going to give you almost 100% coverage of B-frag and most of the other enteric anaerobes, gram-negative anaerobes. And again, no mycoplasma, no mycobacteria coverage. All right, so that's these guys. So let's just really briefly jump into one last group, and that is the semisynthetic penicillins. And this will be a good bridge to the cephalosporins. So we have semisynthetic penicillins. And that is, of course, methicillin, which was the prototypical one. We have oxacillin, and we have nafcillin. And really, whether you're using oxacillin or nafcillin, these two are, of course, still available. Depends on who your hospital is contracted with. Nafcillin is probably a better antibiotic with less toxicity than oxacillin, but oxacillin seems to be the one that is more widely used for whatever reason. So I guess it's just cheaper and they gave better deals. So, what do these work on? So, what makes the semisynthetic penicillins important? Well, the answer is simple. They are resistant to beta-lactamases. So we talked about inhibiting the beta-lactamases, right, by using this using these additional agents to kind of crash into the beta-lactamase and destroy it. The semisynthetic penicillins are just resistant to beta-lactamases, and that's why they work. So if we look at Staph aureus, what percentage of so I'll ask this question. I usually get a few people on this one. What percentage of MSSA is susceptible to methicillin? Think about it for a second. The answer, you're going to hate me for this, 100%, right? By definition, it is susceptible to methicillin. So 100% of MSSA is susceptible to methicillin. But about in the community, and it varies very widely depending on where you are, anywhere from 30 to 60% of Staph aureus are MRSA, which means, in fact, the majority, in most cases, the majority, if not even less than that, the majority of Staph aureus still is MSSA, and most of the infections we see in pediatrics still remain to this day MSSA, but MRSA is out there. So what was the deal? Well, remember, almost all Staph aureus produced a beta-lactamase, right? Remember that? So penicillin wasn't going to get you very far unless you happen to be lucky and got that 1 to 5% of Staph aureus that never got the memo and made a beta-lactamase. But all of the rest of your Staph aureus is making a beta-lactamase. But when you're MSSA, these semisynthetic penicillins are resistant to that beta-lactamase, meaning the beta-lactamase just doesn't cut them up, which means you can kill Staph aureus again with these as long as it's MSSA. Now, it's not going to work on MRSA, and why? Recall what was the reason? The reason was altered penicillin binding proteins. Remember the MEK gene, and making that PBP2A, and so you're stuck. Because they're semisynthetic penicillins, they pretty much just work on Staph aureus and group A strep and group B strep, and that's it. Interestingly, these tend not to work very well at all on viridins and pneumococci, so you just have to be super careful about that. For whatever reason, they just don't seem to work quite as effectively on these. And so that is a really important little caveat, is that yes for MSSA, yes for group A strep, but no for viridins and no for pneumococcus. So just be really careful of that distinction. And that's like I was talking about, you'd like to just say, oh, gram positives, right? Oxacillin works on gram positives, but it doesn't. It doesn't really work on fecalis, doesn't work on faecium, doesn't work on viridans group streps. Just works on MSSA, won't work on MRSA. So really important not to. Because they're based on penicillin, they have no gram-negative activity. Of course, no atypical coverage, no real anaerobic coverage, and no mycobacterial coverage. So these are very useful for group A strep and MSSA infections and not very helpful for just about anything else. And remember, again, with group A strep, does it produce a beta-lactamase? The answer is no, it does not, which means why use oxacillin when you can use penicillin? So really, these are just here for MSSA infections, and that's about it. Okay. And then what we'll do is at the very end, we'll talk about the toxicities of all of these different things, since there's quite a bit of nuance and difference, but then there's also a lot of similarities. All right, so speaking of beta-lactams that are resistant to beta-lactamase, let us talk about the cephalosporins. So here, let's just do away with this whole thing. And get going on those. All right, so where's my selection? Let's select you. Boop. Copy, and we will paste you. Just in case I end up getting excited and write over my thing, I don't ruin it again. Let's move it down a little bit. All right. That's probably pretty good. Right, so the cephalosporins, let's pick a different color, shall we? Let's do this maroon. Okay. Cephalosporins. And the important thing about cephalosporins, uh-oh, I think my